This meeting is being recorded.
Hello, everybody. Welcome to Grand Rounds. Welcome to Matsuo as our new chief resident. And a big welcome to our special guest today, Dr. Krystal Cleven. She is an internist and board certified also in pulmonary and critical care medicine, who focuses on research in the respiratory health of 9/11 FDNY first responders, specifically in post 9/11 sarcoidosis and other respiratory diseases. She is on faculty at Montefiore, where she is the co-director of the Montefiore Asthma Center and sees patients with severe asthma. And we thank her for joining us today. Dr. Cleven.
Thank you. So I have two screens, so I may look this way, but I know the camera's here. I'm going to be speaking to you today about respiratory diseases in FDNY rescue recovery workers after World Trade Center exposure. So there are many cohorts of people who were exposed, who were studied, who were exposed to World Trade Center exposure. But I'm going to be speaking about the fire department specifically. So first, next slide. Sorry, I'm going to forget that I have to say that. Next slide. My disclosures, I don't have any financial disclosures. Warning though, I'm going to be speaking about 9/11 and World Trade Center disaster, and I will show some pictures. I like to warn people of that because they're still pretty upsetting even 20 years later. Next slide. So the outline of the talk, I'm going to speak about the background of the fire department World Trade Center exposed cohort and different levels of exposure to World Trade Center dust. Different diseases that were diagnosed, like World Trade Center cough, the pulmonary physiology after World Trade Center exposure, so how the pulmonary physiology of these folks changed, World Trade Center sarcoidosis, lung cancer in FDNY workers, and then future directions for our cohort. So next slide. So background information, I'm realizing that every year I give this talk, the people I'm speaking to get younger and younger. And that pretty soon we will have interns that perhaps have no memory of this or were not alive, which is wild to me, but I was in college. So it's always kind of morbid, but also good to remember what happened on that day and how many people were impacted and why this work is still so important. So on 9/11, two planes hit the World Trade Center towers, and there was a massive dust cloud with blackout conditions and fires that burned all the way through December 2001. So the majority of the exposures, right, were at the time of the, and then after that happened, the towers collapsed. So there was a huge amount of this massive dust cloud, is like those pictures I'll show you where the dust cloud engulfs people who are there. What they were exposed to was pulverized construction material, asbestos, glass, silica, fiberglass, concrete, lead, and other metals, and jet fuel. And then the fires that burned for months afterwards. Now, there was not adequate respiratory protection at the time of the disaster. I mean, no one knew this was going to happen. I mean, firefighters have the best PPE on the planet, especially the New York City Fire Department, and they still didn't quite have it ready for this moment. And of course, people just walking about didn't have anything. Now today, a lot of us have N95s or at least a surgical mask in our pocket, and probably would help a little, but at the time, people didn't have that. The nearest air quality monitors were destroyed on 9/11. So actually, because of the air quality issues last week, I tried to look at what the particulate matter 2.5, which I'll talk about those sizes in a bit, what it was around 9/11. And interestingly, the levels from the monitors that were not destroyed were not really increased in the area, which is really interesting because I assumed it did. But the levels we saw last week were worse than around 9/11, but of course not at the site, but I mean just like if you were in northern Manhattan or in Jersey or somewhere a little further away. And of course, no one was wearing individual monitors, so we don't know what anyone's individual exposure was. Okay, next slide. Next slide. Can you go to the next slide? Okay, great. So World Trade Center dust consisted of highly alkaline particulate matter. So particulate matter is abbreviated PM. Particulate matter is basically dust particles and things floating in the air. And the size of these particles were really massive, like well over 10 microns, which is big. Now, if you look at this picture on the right, normally what happens in your respiratory system is your oral pharynx, your nose, your throat, your trachea, all filter out things that are greater than even 5 microns. So 10 microns should really not even get past your nose. But because the dust quantity was so large, it got past all of these defenses we have to keep big particles out of your airway. So we ended up, not we, my colleagues ended up, there's a small study of maybe 3 patients, I think from Bellevue, where they did bronchoscopy, and they saw large particles even in the deep part of your lungs, like right here in the where the alveoli are, huge particles that we never thought could get that far because the system was just so massively overwhelmed. So normally, you know, if the particulate matter is over 5 microns, it doesn't really pass the throat. If it's between 1 and 5, it can get down to like the main bronchi. And then if it's a little smaller, like 2.5 or even smaller, it can get to the alveoli or the very end of the lungs. And that's where you see a lot of systemic problems because your capillaries absorb some of that too. And you have increase in cardiovascular disease, you have increases in asthma, respiratory complaints, even cancer, dementia, all these things from more chronic air pollution exposures, especially the small particles like PM1 or 2.5. But this exposure was so massive that it overwhelmed the whole system. So the extent of dust exposure coupled with increased respiratory demand on those who are doing rescue and recovery work really resulted in the lower airways being impacted more than we sort of would have realized was going to happen. Okay, next slide. So over 100,000 rescue recovery cleanup workers and survivors were exposed to dust, fire, and other hazardous conditions. So in the fire department, we had about 17,000 folks that were exposed. And then a total of 70,000 non-FDNY workers, so other people who were cleaning up, police officers, stuff like that. Tens of thousands of area workers and residents, people who were going to work, people who lived there. The day of the disaster, 343 FDNY workers died. And then since then, you know, I looked up this number probably a month ago, about 300 people have died from World Trade Center related diseases since 9/11. Now the number may have exceeded those who died on the day of the disaster. Okay, next slide. Now I'm just going to be talking about the fire department, so that's the yellow bar here, but there are lots of other cohorts that are pretty big. So the fire department has about 15,500 people who are in our study cohort. So 15,500 people who were exposed on 9/11 or cleanup afterwards. And then general responder cohort is in this pinkish color here on the left, which we call general responders. So those are about 66,000 people who are non-FDNY rescue recovery workers, like police officers, other cleanup crews, other EMS workers that don't work for the fire department, etc. Then the blue are survivors. That's 36,000 people. Those are people who just kind of happen to be there. They did clean up and volunteer afterwards, but they weren't part of like an official like FDNY or something like that, or NYPD. And then much smaller is the Pentagon Shanksville exposure. I'm not going to talk much about that cohort, but you know, they were exposed also. It's a much smaller group though. That's only about 1,200 folks. Okay, next slide. So at some point early on in the research of this, you know, I was not part of this group, this research cohort when consortium when it first started, but my group and others sort of came up with this different groups and exposure gradient. So if you were there on 9/11, the morning, you were caught in the dust clouds. You were there before the towers collapsed, but then the dust cloud engulfed you and your airways. So that's considered a very high exposure. Arrival group 2 are people who came by 9/11, but in the afternoon. They also have significant dust exposure, but they weren't there caught in the dust cloud per se. Arrival group 3 is the next day, 9/12. Those folks are considered moderately exposed. Group 4 is 9/13 to 9/24. So it rained on 9/13. So the amount of dust in the air decreased. And then arrival group 3 is considered anyone who came after 9/24. When fires continued to burn, but there was less aerosolized dust. Okay, next slide. So this is a breakdown of our cohort. So about 2,200 folks were there in the morning and were engulfed in the dust cloud. Like I said before, about 343 died immediately upon the towers collapsing. Now, the arrival group 2 are those who came in the afternoon. So once this happened, almost half of the cohort was there. So by the end of the day on 9/12. So that means almost half of our cohort was most heavily exposed. And then on 9/12, more people arrived. This is the first time of arrival. Once they came every day. They were able to work. One thing I've learned about firefighters is it's very hard to convince them not to come to work, even if they're sick or whatever. They did this work for a reason, and they will come to work under basically any circumstances. So, and then 9/13, it rained, more people arrived, and then you can see fewer people arrived later. Those people who arrived later are usually people who were away on vacation when this happened, were already on some sort of disability. Many folks came out of retirement to work. Those people probably came a couple days later. Okay, next slide. So this is the demographics of our cohort. So our cohort is predominantly male. So 99% of other firefighters are male. EMS is a little less, 8%, but still majority male. The whole cohort is about 96%. Race, it's majority white cohort, especially in firefighters, it's 93%. And then EMS is about half, 51% white. But the EMS group is smaller numbers overall. So overall, the cohort, majority 86% are white. Age on 9/11 was about 40 years old, a little bit younger in EMS, but the median age is 39. And then and now they're 60, so 20 years, the median age. Ever smokers, about a third of our folks smoked at some point. And then percent that are currently retired, this is reaching about 80%. So we're 75% now. You can retire after 20 years of being in the fire department with full benefits. So if you're able to work, most folks stay in for 20 years, and we've reached 20 years. So, but it's not like everyone who started on that day started that day, right? So some folks had already been working 10 years and the disaster happened. So, they've retired since then. So, okay, next slide. So what's really unique about our cohort, and it separates us from all the other cohorts, is that our cohort has been collecting data prior to 9/11. So respiratory data specifically, cancer data, all these data, health data on these folks. So prior to 9/11, active firefighters and EMS workers received medical monitoring and treatment through the FDNY occupational health. So we already had a well-oiled machine here in terms of taking care of folks, screening them for health conditions and monitoring them, because it's a dangerous job, firefighting. So you have to make sure they're healthy and fit to do that. We started to collect data electronically beginning in the 1990s, including pulmonary function tests, which actually were collected before that, but electronically where we can easily pull those data and not look at paper pulmonary function tests was in the 90s. So we started monitoring folks immediately for health conditions. So like weeks afterwards, we already had a medical monitoring program up and running. Other cohorts took a little more time. They had to get funding, they had to get people to do it, they had to get organized. They didn't have pre-9/11 data on most folks. You'd really only have pre-9/11 lung function tests if you needed it, right? Otherwise, why would you have that done, right? Most of us don't have spirometry done for no reason. So in 2006, we secured funding, and we were able to invite World Trade Center exposed retirees to come back for annual medical monitoring and treatment. So funding through this is passed in 2011. The Zadroga Act pays for World Trade Center medical monitoring and treatment through, I think we have like 70 something more years left. So everyone's care will be paid for, not for every condition on the planet, but for those that are deemed World Trade Center related. And as a result, we have a very good retention rate. We're probably the only cohort when we send out a survey gets like 80% return. You know, that never happens when you do a survey, right? Or even 90-something% return. Okay, next slide. So the data collected annually since 2001 were, and actually prior, were, I don't know why I wrote 2001. Oh, we started doing it annually, but we were collecting some of these data before. So demographic data you have at time of hiring. Height, weight, BMI, lab data, regular lab data we started doing after 2001, and I think we only did it as needed before. Spirometry and chest x-rays we were doing long before 9/11. Self-administered physical and mental health questionnaires, and we've added on to the questionnaires over time when we started to see things come up. And also, like, for example, COVID. So whether you're diagnosed with COVID, what treatment you had, that was added later, obviously, when we needed it. Okay, next slide. So some of the conditions diagnosed after World Trade Center exposure and that are sort of certified conditions are chronic rhinosinusitis, and you can see that's high in both groups, survivors, responders. Now, when I say responders, I mean like all responders. So us, our group, and then the other non-FDNY rescue recovery workers. Survivors are people who were volunteering or just in the area at the time. But you can see chronic rhinosinusitis is very common. GERD is a very common diagnosis associated with World Trade Center. Various cancers, asthma, sleep apnea, PTSD, obviously, different chronic respiratory disorders. World Trade Center exacerbated COPD, so folks who had COPD and then it was worsened after this exposure. Anxiety or major depression. Okay, next slide. So now it's not just one diagnosis, right? Some folks have multiple diagnoses, multiple physical health diagnoses and multiple mental health diagnoses, or both. So about 11,000 of our members have at least one certification to date. So it means they were told, yes, you have this diagnosis. Yes, it's from World Trade Center, right? The other 4,000 or so, they may have a mental health diagnosis too, or they don't have an official diagnosis but are willing to do annual monitoring anyway, which is great, very helpful for us, because if things pop up that are diagnosed later, we can certify them and everything's paid for during the monitoring anyway. But if you start to need medication, then it's paid for. Members with at least one physical health certification, that's 9,800. And then members with a cancer diagnosis related to World Trade Center is 3,000. And the members with one mental health diagnosis is about 4,300. Like I said, there's a lot of overlap. Some people have, physical health, mental, and cancer, or one or the other, right? Okay, next slide. So what I want to demonstrate on this slide is that there's sort of a dose-response relationship to the amount of exposure you had. So basically, for every diagnosis you put on the slide, this is just in the fire department, but it's been shown in the other cohorts too. If you were there on the morning of 9/11, which is this red bar, versus or the afternoon, which is basically the highest exposed folks, you are more likely to have one of these post 9/11 diagnoses. So GERD, chronic rhinosinusitis, asthma, chronic bronchitis, and COPD. I focused on respiratory diseases because I'm a pulmonologist, but you can put a lot of diseases in here, and there's a dose-response relationship. If you were more exposed, you are more likely to have this diagnosis, one of these diagnoses. Okay, next slide. So one of the most common complaints after 9/11, virtually everyone complained at some point in the first week, like in the first week, basically 100% of people said they had cough, which makes sense. And then about a month later, about half the cohort still had cough. So, and then about a year later, about 45% still had chronic cough. And then many years later, 30% still were complaining of a chronic cough. Now, I don't know if I mentioned this, but to join the fire department, especially to be a firefighter, you cannot have any lung problems. So some may be wondering, well, what if they had asthma before? What if they had a cough before? You cannot be a firefighter. You must have perfect lung function. In fact, most of them, the majority, have above normal lung function. And if you have any symptoms, they do a methylcholine challenge test to try to provoke asthma, basically. And if it's positive, you have to retire. So EMS workers, there's a little more flexibility because they don't have the same exposures. But basically, this is a very, very, very healthy cohort. These are not people who come in with respiratory issues. So we can safely conclude that all these diagnoses after 9/11 were from 9/11 and did not predate 9/11. Some people smoked, of course, so some people are going to have COPD, but at some point in their life, potentially, but they shouldn't have asthma or chronic cough. So if you look on this graph here, cough was very prevalent. This is a year later, right? So this is like 1 year later. So it's about half still had cough. Now that after 2 or 3 years, it decreased significantly, but still a lot of people had these persistent symptoms for years, 20 years later, still having wheezing intermittently, cough, shortness of breath, who did not have it before. So at some point, they defined World Trade Center cough syndrome as people who had cough with symptoms severe enough that required greater than or over 4 weeks of leave. And like I said before, firefighters are very hard pressed to go on leave. So to go on leave for 4 weeks or more, it must be very significant. And it's not just cough, it's a constellation of symptoms. It's GERD, chronic rhinosinusitis and cough usually together, or some lower respiratory symptoms and upper respiratory symptoms together. So it's a little bit of like a unique set of complaints in this group. Okay, next slide. So my colleagues looked at who qualified based on this definition of World Trade Center cough. So who had a cough for more than 4 weeks, and then what were the features of this group? So they looked at a case series of 332 members, and like I said before, like other conditions, the incidence of World Trade Center cough syndrome increased with higher World Trade Center exposure. So if you arrived on 9/11 versus arriving later, like on 9/24. Who had upper airway symptoms? Upper airway symptoms are like nasal, throat, like GERD, nasal congestion. That's considered upper airway, right? 87% had GERD, 54% had nasal congestion. Some had both. Lower airway symptoms, so shortness of breath, wheezing, those are considered lower airway. The majority of the cohort, 95%, 57% had wheezing. Again, some had upper and lower complaints. Some had all 4 of these complaints. And then they looked at they did spirometry and actually pulmonary function testing, and they first did a pulmonary function testing, gave bronchodilators, albuterol, and then measured the response. And so if you had over 12% improvement in your FEV1 and 200 milliliters, so that's the classic definition of bronchodilator response, then they considered that positive. That was 63% of the group. Now, again, these folks did not have this pre 9/11, so this is a new thing for them. 24% had bronchial hyperreactivity. So bronchoprovocation challenge testing is what they did. So they did it on people who did not have a positive bronchodilator response, but had a lot of symptoms. They got methylcholine challenge testing. So what that means is you do a breathing test, then you give something to sort of provoke hyperreactivity in the airways, and you do another you do spirometry serially during this test, and you give increasing doses of methylcholine. We used methylcholine. And we saw about a quarter of the group was hyperreactive, which again should not have been the case prior to 9/11. Okay, next slide. Now, the pathophysiology of World Trade Center, after World Trade Center, what we saw when we did pulmonary function tests on everyone, so full tests, and just looked at spirometry, was mostly obstructive physiology. So air trapping, like I said, some had a response to bronchodilators, airway hyperreactivity, and then FEV1 less than the lower limit of normal, which is abnormal because everyone had theirs above the lower limit of normal before. So within 2 years, 20% of firefighters, at 2 years of 9/11, 20% of firefighters had an FEV1 less than the lower limit of normal. That wasn't true before. 13% had it persistently in 10 years later, or 12, 13 years later. And these folks were probably forced to retire if they had a positive, or if they had it depends on how low it was, but some of them were forced to retire, but then continued to be monitored. Very few had restrictive disease. So that is sort of something we are looking at now, because like something like interstitial lung disease takes a little bit of longer to develop. And this is where I note that the firefighters had normal lung function before. Does anyone have any questions? I guess put them in the chat or just interrupt me. I should have said that. We should have a little time at the end though. So my colleague in 2016 wanted to look how persistent these findings were. So they did, like I said, bronchial hyperreactivity testing in those early on in the baseline, they call it baseline time. And then they basically repeated it to see how many people that was persistent in, right? So some people actually develop bronchial hyperreactivity later, but this isn't the whole cohort. This is just a small percentage of the cohort. But this graph demonstrates how many folks had symptoms, what percentage had symptoms. Oh, sorry, next slide, sorry. Cough, dyspnea, wheezing, and abnormal FEV1, so less than the lower limit of normal. And how many of those within these symptom categories, some had multiple symptoms, by the way, had bronchial hyperreactivity, and how many did not. So it's 50-50 in a way. Some people had cough and didn't have bronchial hyperreactivity. So basically, and then some did. So basically it's a little hard to, what we summarized after looking at this, because even at follow-up, that was still the case. You know, the people who had a bronchial hyperreactivity were more likely to have persistent symptoms. As you can see, these blue bars start to exceed the red a little bit more. So more people who had bronchial hyperreactivity continue to have symptoms. But what's interesting to think about here is that, you know, some folks have symptoms and we can't explain it with tests. That's the bottom line. So our regular tests, spirometry, still were normal in some of these folks, even though they had really annoying persistent symptoms 10 years later. Okay, next slide. Now these next few slides I find very interesting. So this is the adjusted FEV1 in liters. So this is in liters. So it looks less dramatic, but the next slide actually, let's go to the next slide because it's much more dramatic. Now, if you look at FEV1 percent predicted, so when we look at percent predicted, we're looking at someone's forced exhaled volume in 1 second. Sorry, I didn't say that. I forget I'm a pulmonologist and not everyone here is. And then you compare it to what is expected based on your age, your sex, your height, and we do based on race, although just very recently, ATS, American Thoracic Society, has recommended to use race-neutral norms, but the data we have is from prior when we were using race as an adjustment factor. I mean, most of our cohort's white, so it probably doesn't matter that much, but so what normal is above 80%. So you want to be above 80% of predicted, especially if you're going to be, you don't want to be diagnosed with asthma, right? So as you can see here, prior to 9/11, which is on the x-axis is negative 1.5. So that means a year and a half before 9/11. You can see most of our folks, regardless of when they eventually arrived on 9/11, they're above 100%, right? Like I said before, they're like superhuman, right? So they're like 105, 110%. That's a median, okay? So there are people who are even higher than that. And then on 9/11, which is time 0, and then after that, really, like a year and a half later, there's a huge drop off. I mean, it's huge relative to what it was like before, but these folks already technically still had normal lung function, right? But you can see here that there's a huge hit, so there's a decrease, and then they never go back to how they were before. And this is adjusted for age. They never go back to the group. Never goes back to 100% or above 100%. I mean, we're close. They're 95, 90 is still excellent, but you can tell there's a hit and they never recover in some ways. Okay, next slide. And then my colleagues teased apart this group a little bit more. They looked at, okay, most people who had the expected FEV1 decline over time, you know, they had like this big hit, like you can see in the gray line how it goes from 105 or so to like 95 or something. And you can see it kind of like trucks along. It's flat, which is expected, right? It's always adjusted for age. But you can see this red line. We identified folks who had what we call accelerated decline in FEV1. So people who had over twice the amount of volume function loss as the rest of the cohort. So this is a very interesting group. It's a small number of people. This is actually in a group of non-smokers, this study. So it's interesting to see that some people, for whatever reason, have this insult to their lungs and they never recover, and then they continue to decline pretty rapidly for 20 years, and they continue to. But if you look at, you know, the gray line, those people, you know, did what any normal person does, is a small decline in lung function every year with age. Now, I kind of skipped over this one, but if you, one of the slides from before, I'll just tell you, you don't have to go back. You actually go back a couple more slides, 2 more slides. Yeah, that one. So this is raw liters, right? So, you know, it doesn't look as dramatic as the slide I focused on, but actually when you think about it, these folks dropped like a half a liter on average. This is all in non-smokers, by the way. The average decline in FEV1 in the first year after 9/11 was half a liter, which is pretty significant considering what's normal is like 25-ish milliliters per year. So half a liter is kind of massive drop. And, you know, it tapers off. They don't keep losing half a liter a year forever, but it's not insignificant. I certainly wouldn't want my lung function to decline that much. Okay, you can go forward to slide 23. Yep. So initial studies noted that the use of inhaled corticosteroids really had no effect on airway reactivity, but did slow the rate of FEV1 decline. So, you know, it's a little bit of unique exposure. So we tried to apply normal treatment, right? Normal asthma treatment to these folks, and it didn't always work. But later studies that were published more recently showed that those treated the earliest with inhaled steroids had the greatest improvement in their decline in FEV1. So although maybe it didn't help with airway reactivity as much as we wanted it to, it did help slow down this like decline in FEV1. So we do recommend, you know, early and serial pulmonary function testing, including bronchial hyperreactivity testing. So, you know, methylcholine challenge testing, even if their results are normal, in people who have these occupational exposures, because they're going to be a healthier group. Usually they're working, so there's this healthy worker effect. So you have to have like a little bit more suspicion than your average patient. And even if their spirometry is quote normal, you should still say, no, this person has persistent symptoms. We need to look into this a little bit more. And, you know, I don't treat the patients in the fire department as a pulmonologist, but my colleagues who do still treat with inhaled steroids, even if their spirometry is technically normal, if they have symptoms that are very consistent with airways disease, because we've found it helps over time. So we recommend inhaled corticosteroid therapy early for those with symptoms or abnormal lung function. Of course, then it's an easy decision to make because it slows the decline in lung function. Okay, next slide. So we're going to switch gears a little bit. So sarcoidosis is an interstitial lung disease. So it's a systemic disease. So it's a granulomatous disease with an unknown etiology. And there's this theory that you're sort of genetically primed, and then you have some abnormal immune response to an exposure. And there's multi-organ involvement, most commonly the lungs, but you can have basically every organ can be impacted. And sarcoidosis rates were higher in firefighters in the general population before. We knew that before, and I'll show you a graph, but 2 times higher than the age, race, sex matched cohorts. Sarcoidosis rates increased even further though after World Trade Center. So there's some bias here in that we do an X-ray on everyone every year before 9/11 and after. So we're gonna just catch a lot of sarcoidosis, but when you look at similarly followed cohorts that are not firefighters, we still have higher rates of sarcoidosis. Okay, next slide. So you can see in this bar graph here in the blue, this is pre-9/11. So this is our number of new cases of sarcoidosis every year. It's not a huge number, but, and then you can see in the red an increase, right? That's pretty obvious. So this is, it's not like, it's a little misleading, these bar graph. It's not like it peaks and it went down. This is new cases every year. So, you know, most of the cases were diagnosed, you know, earlier. And then 2015, we had fewer like new diagnoses. They were already diagnosed closer to 9/11. Okay, next slide. So we looked at these folks. So we looked at we found 74 incident cases after 9/11, between 9/11 and 2015. They all had normal radiographs prior to 9/11, and most of them were biopsy confirmed. We looked at 59 firefighters, all biopsy confirmed sarcoidosis, pulmonary sarcoidosis, and we did an extensive multi-organ evaluation. This was my fellowship project I worked on with a colleague, Dr. Henna. It was really her project, her baby. She just let me join, which was great. And looking at extensive multi-organ evaluation and questionnaires done at the time of the diagnosis. So questionnaires were done at the time they were diagnosed, and then again in 2016. So I worked on this 2015, 2016. So this follow-up was about 8 years on average, the median after the time of diagnosis. So most folks had had sarcoidosis for about 8 years. Okay, next slide. And you can see at baseline, we had acquired a lot of information about these folks. Like I said, we have chest x-rays every year and pulmonary spirometry at least. But once you were diagnosed with sarcoidosis, even at baseline, we had a lot of data. We got CTs, chest that you had gotten from somewhere, full pulmonary function tests, at rest oxygen levels were measured, EKGs, echocardiogram, 24-hour heart monitoring to look at irregular heart rhythms, regular basic labs. This is just like basic care for sarcoidosis. A complete ophthalmologic exam was done on everyone at baseline, and then general physical exam. And then when I worked on the study in 2015, we repeated all these tests and sort of expanded it further. So again, we did another CT, we did another pulmonary function test. We measured their oxygen at rest and with walking. We did an EKG, we did an echocardiogram, we did 48-hour heart monitoring with something called the Zio patch, which sticks on and measures your heart rhythms. We did that for everyone. We also did a cardiac MRI on everyone. So this is unique. Most studies on sarcoidosis will not do that. And I'll show you on the next slide the normal workup for this. Blood tests we did listed here. We did a beryllium test because beryllium can look a lot, berylliosis can look a lot like sarcoidosis. So we had to see what the level of beryllium exposure was, and ended up no one had a positive beryllium spot test. But we did an eye exam on everyone and physical exam. You can see here, sorry, next slide, 98% of folks had pulmonary involvement or lung intrathoracic involvement. So lymphadenopathy, pulmonary lung involvement was in most folks. And then about 8 years after diagnosis, or when we did the follow-up in 2015, about half those folks had persistent findings. Some people it resolved, their lymphadenopathy resolved, their lung involvement resolved, which happens a lot in sarcoidosis. So this is kind of expected. Cardiac involvement, at baseline, we had 0 people. Of course, we didn't do a cardiac MRI on everyone in the beginning. We only did it during follow-up, but you can see an increase. So 16% of folks now had cardiac sarcoidosis. Joint involvement also increased, went from 7% to 15%, and that was based on physical exam and questionnaire data. Okay, next slide. So this is the normal workflow is demonstrated here for cardiac sarcoidosis. Normally what you do is you get an EKG, right? And if someone has a unremarkable EKG and they don't have symptoms, you don't really have to do anything else. But we kept going. So let's look at the top here. Let's see someone has an unremarkable EKG, and we did an echocardiogram, and we found no one had an abnormal echo in this group who had a normal EKG. But we did further testing. We did the Zio patch. So if you move over to the right one more, you can see 7 people out of 39 had an abnormal Zio patch reading. So some arrhythmia that was concerning. And then everyone got a cardiac MRI, and one of those people who had if you look all the way back to the left, they had a normal EKG to start, screening EKG. They ended up having an abnormal cardiac MRI that was consistent with sarcoidosis. If you go back to the far left, you can see, unremarkable EKG, unremarkable echo. Normally you would stop testing, but we kept testing. Unremarkable Zio patch. Normally, in the normal clinical world, you would stop testing. And we did a cardiac MRI, and we found 5 of those folks had cardiac sarcoidosis. Now, if you look at the bottom here, where it says abnormal EKG, that's 20 people. You kind of follow the same flow. And you can see we had people who had unremarkable testing after the EKG testing, which you would normally stop, and found one of those folks at least had a cardiac sarcoidosis. Now, in the interest of time, I am kind of going through this quickly, but bottom line is what I want to tell you is that 9 folks had abnormal cardiac MRI. So abnormal meaning it was consistent with sarcoidosis. 6 out of 9 of those people would have been missed if we had done it the normal way. So done an EKG, it's normal, stop testing. Or do an EKG, abnormal, do a TTE, and then if that's normal, you stop testing, right? Now, in my clinical practice, if someone has sarcoidosis and they have symptoms, I kind of follow this workflow now, because once you find out cardiac sarcoidosis isn't something you want to diagnose late, because it means they may have a fatal arrhythmia and die. There's data, at least in Japan, which has a higher prevalence of cardiac sarcoidosis, that postmortem on autopsy, people are diagnosed with cardiac sarcoidosis more than expected. Now, that's not the time to diagnose cardiac sarcoidosis, right, in the morgue. So I don't want to be scary about it, and it's a controversial thought, and I know a lot of cardiologists don't always agree, although with us on this, but I know a fair number are coming around to being a little bit more aggressive about testing. We've had people waiting for heart, die from cardiac sarcoidosis. The majority, though, who ended up needing EP studies and who some needed an AICD, most of them have not had it fire off, so that's good. But they definitely had concerning rhythms when they did an EP study. Next slide. So our study showed, when we look back at those who had sarcoidosis and the kind of systemic involvement they had, none had evidence of beryllium sensitization. Nearly 68% were highly exposed, so they came on 9/11. 24% required treatment for sarcoidosis. So one thing to note about the treatment of sarcoidosis in our cohort is that the majority of folks who had cardiac or joint sarcoidosis, they were not always controlled on steroids. Most of them were not. And then the normal workflow is then you try methotrexate, and then most of them, though, needed a higher level of therapy, which is anti-TNF alpha agents. Now, this talk isn't about just sarcoidosis, but basically what I want you to take away from this is that the majority of folks with cardiac and joint sarcoidosis didn't respond clinically to treatment in the same way that we usually see in like a non-exposed cohort. Although joint and cardiac sarcoidosis is relatively rare, so it's a little bit hard to say. Now, I have a couple more slides on lung cancer, or I can just take questions, whatever you guys want me to do. It's not many slides.
I think you can go ahead and continue.
Okay.
Yeah, thank you.
You said you want me to go ahead and do lung cancer, right?
Yes. I mean, if
Okay.
you a few bottles finished, then I think.
Yeah.
Thank you.
So go to the next slide, slide 31, I think. Yeah, great. So generally, firefighters have a 15% or so increase in the rate of lung cancer. But actually in our cohort, it's a little bit lower. That's for lots of reasons. So like I've been saying a bunch of times, is that the FDNY firefighters are like superhumans. They're really healthier than the average person. So a strong healthy worker effect. We had a very successful smoking cessation program early on, so that helped. That's probably why our rates are a little bit lower than the average firefighter in the country. So next slide. So in, I don't know when we started the study, it was interrupted a bit by COVID, but so sometime year before COVID, we decided to, so, you know, there's a recommendation now for early detection of lung cancer using low dose chest CT. It reduces mortality in those who qualify for screening. So at the time we did this study, the screening was 50, and I still have this on the slide, although the USPSTF has changed the recommendation since then. But at the time of this study, you needed to be 55 to 80 years old, smoke more than 30 pack years, and be a current smoker or quit within the last 15 years. That was the screening criteria at the time for lung cancer. And right before we published this, the guidelines changed. But USPSTF, they're not the only people who put out guidelines for screening. You know, you probably know that for all cancer screening, there's multiple agencies that are sort of stakeholders in this and have different recommendations. So the National Comprehensive Cancer Network has two different criteria for lung cancer screening. One that matched USPSTF's old recommendation, and then category 2, which actually expands it to people who have occupational exposures. So they always had the recommendations to screen at 50 years, over 20 pack years, not 30, and then they have no timeline for quitting. So if you quit 20 years ago, it didn't matter. You should still be screened if you had these other two criteria and occupational exposure or family history that would increase your risk of lung cancer. So that's firefighters fall into that category. So we screened a lot of folks for lung cancer outside of what USPSTF would normally recommend. And so many of our cohort members, because of symptoms, ended up having a CAT scan at some point. So what we did is we looked retrospectively and we applied the risk factor guidelines, these two different guidelines, plus these different models. So you can put in a stats model, like these different features of a person's smoking history and their age and their race and all these things that increase your risk of cancer into a model. And if your score is above a certain amount, they recommend screening. If it's below, they don't. So we basically retroactively applied these screening guidelines, 2 guidelines and 2 model-based strategies to see, hey, if we had applied these criteria, how many lung cancers would we have missed and how many would we have caught? And which guideline or model is best for our group? So next slide. So we found, I'll go over this quickly, that the study population, if you go to the third dot, is about 3,900 folks. We included everyone over 50, everyone who smoked ever, even a small amount, because one of their criteria doesn't, we wanted to be as broad as possible, basically. And about 930 met any criteria for lung cancer screening. And this whole study was inspired by a different study of nuclear power plant workers, I think, that was increased. They found more people had lung cancer than would have been caught by normal screening methods. So that was sort of what inspired us. We found 63 folks with lung cancer, and 50 were detected by at least one of these 4 screening modalities if we had applied them. 13 would not have been detected, basically. They were detected because we were just doing CAT scans on folks for other reasons, but they were detected incidentally for other reasons, like I said. So they wouldn't have been screened and they would have been missed. So if you go to the next slide, you can see the guideline, the NCCN2 guideline, which is more in line with what is recommended. The most number of people would have been diagnosed and fewest would have been missed. USPSTF would have missed a fair number of people. We would have had more false negatives, basically. The different models, PCL, PLCO, and Bach models, which are like statistical models applied to the features of the person, would have missed quite a few people. So basically, I want to highlight, next slide, is that we at the time of this paper, USPSTF had just changed their recommendation. So we supported that change. We think it's important, especially for occupational exposed folks. We will, though, continue to screen folks who quit more than 15 years ago, though, because we will miss just too many people if we cut it off at 15 years because of their occupational exposure history. So, like I said, it's similar to a different occupational cohort. They also found very similar findings, that if we apply the normal screening criteria to these folks, we're going to miss a lot of people. So that's the point of this slide, basically. So last slide is what we're doing next. So we're in the process of publishing a paper about specifically pulmonary fibrosis, the prevalence and the clinical features of those folks, because that develops a little bit later after an occupational exposure. So stay tuned for that. That'll be published soon. We're in the final editing stages of that paper. And then really highlighting the importance of patient-specific screening for unique disease presentations. Like sarcoidosis looks a little different than the average population. Lung cancer risk is different than the average smoker. Prevalence of these diseases is going to be different, so you have to be a little bit careful when you're taking care of them and making sure you're kind of up to date on how these diseases present in this cohort so you can treat them appropriately. We continue to work with the other World Trade Center exposed groups. We have meetings annually, or twice a year actually, and we share data openly. We've published together a lot to see if our findings are replicated in other cohorts. And then now there's an interest in like lifestyle modification and interventions to improve lung function or other respiratory complaints related to World Trade Center. So that's it. Actually, you can go down to the thank you slide so everyone gets there. Sorry, I know that was rushed at the end, but.
Oh, thank you. Thank you so much, Dr. Cleven, for this very interesting topic covering the effect of environmental exposure, in this case, WTC, on the multiple various respiratory illnesses. It was a very interesting topic. Sorry, it's just 1 minute past 1 p.m. right now, but I see just
One question, right?
Question from, yes, Dr. Miller in the chat, asking what percentage of the, I guess, the WTC exposed firefighters had an accelerated decline in FEV1. I think you showed the graph, but I think the proportion.
You know, when I saw your question, I was like, oh no, I don't know what percentage of people. It's a small percentage, you know, it's less than a quarter of the group, but I don't know the exact numbers off my head.
Let me see if there's a question.
Yeah, the slide I showed didn't tell you what percentage of people had accelerated decline.
I see. Okay. All right. Thank you so much.
Yeah, but it's a small. It's not very large.
Mm-hmm.
For some reason, I think it's like in the teens, less than 20%.
Oh, I see.
Yeah.
If there's no other question, sorry for the initial system.
That's okay. It happens. I don't know why that was happening.
Right. Yeah. But thank you for your time, you know, for us to, you know, share your amazing work in this field. And I think, you know, these days, the environmental exposure, air pollution is a big topic in pulmonary medicine in general.
Yeah.
And then this is really interesting cohort because a lot of them, you know, were basically healthy people, and then seeing, basically investigating the effect solely, the sole effect from the environmental exposure like this. This is amazing. Yeah,
it's true. And like, you know, a lot of the data we have on air pollution, which is something I'm interested in and I have some background in. a lot of the data that exists though is for chronic exposure. Although we have some data on acute exposure, but the World Trade Center was such a massive exposure and such a big difference between being exposed at the site versus being 50 blocks north or something. Mm-hmm. So, I think it's interesting, and I think in terms of like our everyday life, something I'm really interested is kind of getting more nuanced data. So like people having individual monitors that they carry around throughout the day, and we can see what exposures in someone's individual life, which varies dramatically with the like average level that we measure with these regional monitors, probably underestimates the actual exposure people have every day. And this World Trade Center is an extreme example of that. But I think in everyone's everyday life, they probably have huge variations in their exposure within a city, where they commute, where they live, compared to like even their neighbor or someone in the same zip code. So I'm interested in that going forward. And obviously last week was a reminder that that's really important data that we don't have, that we hopefully should have soon. We all have smartphones. They should measure this stuff for you.
That's true. Yeah. All right.
Yeah.
Right. I think it's 4 minutes past now. So
yep.
I think we're gonna
Thank you.
end this session. Thank you so much
Yep.
for your time for this. Thank you so much.
Yes. Thank you. Bye.